Very good evening, everyone. So in the sea of surgeons and sea of medical oncologists and radiation oncologists, this is probably the only pathology thing. So I was asked to pick up a couple of abstracts from pathology which have come up in the last year, and I picked up two from the US CAP 2023, which was just presented in New Orleans by several people. Because I'm in the midst of I picked up certain things which will help understand both for the surgeons and medical oncologists. So this was an abstract which talked about the grossing and reporting of post-immunotherapy nephrectomy specimens. So this is not a common thing. This is from a single institution, the MD Anderson Institute, and some of the pathologists on board are my good friends in this. Single institution experience of 70 cases. So immunotherapy is being increasingly used as neoadjuvant chemotherapy. We all know that, and in management of advanced RCCs, and these authors present a large cohort of such cases. So just to give a background, when we gross a renal tumor, this is a renal tumor. If there is a tumor, we take 3-4 sections. The dictum in pathology is to take 1 section per centimeter of tumor. But what they have taken out, they designed the study in a way that 70 cases of RCC post-immunotherapy, they evaluated and developed a grossing protocol. And what did they do? They took the whole tumor and grid the whole specimen. So the whole specimen was put it as a grid. They've taken multiple sections, which is probably not feasible in our setup, in our day-to-day practice, but that's what they did. And what they have found that it is important to do this because there is microscopic tumor at different. So even if you don't grossly see the tumor some places, somewhere in the renal sinus fat, somewhere in the perinephric fat, you might find some viable tumor, and that's important. So what was the result? That they found discrepancy between the macroscopic and the microscopic extent of the tumor, and the post-immunotherapy staging may not be exactly translated from the AGCC staging which you use for a radical nephrectomy specimen. So post-immunotherapy staging might be different, and it has to be looked up into, and that's one of the important results of this study. Another important finding, they divided these tumors into 2 groups, Group A and Group B, based on the viable tumor post-immunotherapy. So the patients who had less than 20% viable tumor post-immunotherapy did very well compared to the Group B, which show more than 20% viable tumor. And that's why you need to grid the tumor and take multiple sections so that you exactly know what is the amount of viable tumor. And this is the curve which they have charted out, which can clearly shows that the tumors which had more than 20% viable tumor post-immunotherapy radical nephrectomy, they have done worse compared. So this is an important thing. So these are a couple of papers from PubMed which I picked up, which have now studied a lot of studies are coming on neoadjuvant nivolumab and other immune checkpoint inhibitors before you do a cytoreductive nephrectomy in these patients. So I think this is something which is going to come in the future more and more. And this is a big study from a very, very important institute, the MD Anderson study. So the basic conclusion is that we have to grid the tumor because the microscopy and the macroscopy would be different. The staging might be different post-immunotherapy, and the importance of the amount of necrosis post-immunotherapy is important. A couple of discussion points which I put here maybe can be discussed in this panel is how common is it in India to do resection post-ICI? For the surgeons, how easy, difficult? Aman is here. Maybe I can put this question to him later. And is this a paper cue on how to evaluate the response? And is there any radiological or other tips on radiology how to pick up the response? So that's the first paper. The second paper is again a little relevant in the day-to-day practice. Strangely in India, we have a lot of prostate cancer patients who come early. We have many patients who are less than 50. In TMH, we conducted a recent study in which we have picked about 50-55 below 45 prostate cancer patients. So are there some histological features which suggest that you can do this HRR testing in these prostate cancer patients? This was a study again from Salt Lake Utah University. So this is the background. We know that somatic and germline homologous HRD, HRR mutations are seen in up to 20% of prostate cancer patients, and they are now known to respond to PARP inhibitors. And this study, they hypothesized that the histological patterns might be helpful in saying which patient should go for HRR testing. We have some guidelines. The NCCN has some guidelines. There is a Philadelphia consensus guidelines of 2019 which spoke of this, but I don't think And in day-to-day practice, we refer to it in prescribing this kind of test. So what they did in their design is they took 130 patients with 38 BRCA1/2 positive patients, 36 with non-BRCA1/2 HRD mutations, and 56 as a control group which did not have any mutations. They were evaluated by histopathology to see if the histopathology correlated with this BRCA mutations. The results were a negative study. So the NCCN as well as the Philadelphia says that if you see cribriform pattern, introductory pattern, you may suggest that these patients are likely to be BRCA mutated. Strangely, they have found that neuroendocrine carcinoma, when it comes, they are likely to be BRCA mutated. So there is a case that neuroendocrine carcinoma small cell of the prostate may have a BRCA mutation, and those should be tested. And again, they are bad tumors, and they may be a case for BRCA PARP inhibitors. So this is a table. I will not go into the details of this. We can discuss it out during the panel discussions. And the conclusions and take-home messages are that histopathological patterns, even though there are guidelines which say that they can be predictive of HRD, this study did not find that a marginal increase in neuroendocrine morphology and a high volume cribriform pattern was seen in BRCA1/2 mutation. And so the importance is that you have to decide on a day-to-day basis which patients to send for ancillary molecular diagnosis. Most of them are young patients with a family history, and those are the patients who would be harboring these mutations. Again, the discussion points I would leave is, in your practice, what triggers BRCA testing? Do patients now regularly request for genetic and molecular testing? And do clinicians really in day-to-day practice, maybe we can discuss during the panel, follow the Philadelphia consensus guidelines or the BRCA testing? And as a Eurocare team, I think when you do a genetic testing, you have to have a genetic counselor in place before you actually do this. Thank you very much.